Hello, I'm hematologist oncologist Dr. Tony Talebi. Now we're going to discuss the management of locally advanced cervical cancer. I have the pleasure of being with Dr. Lorraine Portelance, Associate Professor of Radiation Oncology at the University of Miami. Thank you for being here.
My pleasure.
Okay, now let's assume a woman has had a pap smear, which is abnormal, and a colposcopy, which is again abnormal, shows a lesion in the cervix. What happens next for that woman?
Then that woman should be referred first to a surgeon, either a gynecologist who has a special interest in the management of patients with cervical cancer, or definitely if she seems to have a more advanced tumor on physical examination, she should be referred to a team specialist in the management of women with gynecological cancer, and these are the gynecologists and their multidisciplinary team.
Would you please explain the 4 stages of cervical cancer and how is a patient staged?
Yes, of course. So the official staging of women with cervical cancer is going to depend mostly on the findings on the physical examination. And we use for the staging a system which is called the FIGO staging, which is a system used throughout the world and in the underdeveloped country. But in addition, in the United States, we're going to add to this physical examination in the staging process a CT scan of the chest, abdomen, and pelvis if the patient has a tumor which seems to be locally advanced, in order to provide more information in addition to what could be found on the physical examination. The staging for cervical cancer, there's basically 4 level of staging. Stage 1 disease is a cancer which is going to be confined to the cervix. So it's usually a small cervical tumor. These are stage 1, are going to be very small, but could barely be seen by the naked eye. We'll need a colposcopy to see it. Whereas a stage B disease could be, small b up to 4 centimeter and bigger b, bigger than 4 centimeter tumor. And then those stages are going to go up to stage 2, where the cancer starts to spread out of the cervix to extend to either the vagina or the tissue surrounding the cervix. Stage 3, same structures a bit further. And finally, stage 4 disease, where we could subdivide into 4 only still localized in the pelvis, invading the bladder or the rectum, or a 4B, which is in fact the more advanced disease that we could have, where unfortunately the patient has already a diagnosis, disease which has spread to other part of the body.
I see. What are some other prognostic indicators that you look at to tell you whether the patient will do poorly or well?
So staging, as just described, is one of the most important prognostic factors for women who are diagnosed with cervical cancer. But in addition to staging, for example, if a patient undergoes surgery, then we're going to look at other prognostic factors under the microscope. We're going to look at the depth at which the tumor is going into the cervical tissue. We call it the depth of stromal invasion. We're going to look into the blood vessels and the lymphatics and see if we could see cancer cells invading those structures, and we call this lymphovascular invasion. We're going to look at the lymph nodes surrounding the tumor and see if they were involved by cancer at the time of the surgery. And this is also another prognostic factor. And finally, the type of cancer cells to a lesser extent. So most of the cervical cancer are going to be squamous cell type of cancer. Adenocarcinoma, it's controversial. Sometimes somebody see them as, having a poor prognosis. Definitely small cell cancer are going to have a worse prognosis than the 2 others.
I see. Okay, now let's talk specifically. Let's assume the lesion is less than 3 millimeters. What would you recommend for that patient?
So, in general, for a lesion less than 3 centimeters, those patients, they could go for surgery and have a resection of that tumor. And the type of resection that could be done could vary from, for a menopausal woman, from a hysterectomy, or for a premenopausal woman who would like to maintain fertility, we could look into a more local surgery, like removing the cervix to try to maintain the uterus in place. But all this has to be done only in a specialized cancer team to make sure that the right choice is made if we decide to preserve the organ for further fertility.
I think that's very important. Some women especially maintaining the ability to carry a child.
Absolutely. I think we know that, cervical cancer could affect very young women, and then if the disease is diagnosed at a very, very early stage, and, first tests show that there is no spread to any lymph nodes, that there is a way we could achieve a resection with a safe resection margin, that the tumor is small and all that, those women could look into a surgery called a trachelectomy, for example, which will allow them to preserve fertility.
I see. So at what point do you only recommend surgical resection, and at what point do you recommend surgery and chemoradiation?
That's a very interesting question. We don't always know up front, first of all, which women are going to end up having the chemoradiation in addition to their surgery. So when a woman is found to have what we think a very early cervical cancer, as mentioned before, we're going to offer her surgery. And then at the time of the surgery, it will be important that the surgeon proceeds with a good examination of the lymph node and lymph node sampling, and then resection of the primary tumor and resection of the uterus. Once the surgery is done, there will be another specialist called the pathologist who's going to look at the tissue. And then, based on certain findings into those tissues, we might have to add to the surgery a treatment with either radiation alone, when intermediate risk factors are present, or radiation and chemotherapy if, for example, cancer spread was found to the lymph node, if there is any what we call positive resection margin, which means where the surgeon had to cut, there were cancer cell scenes at the cut, or if there's any evidence that the cancer has spread to the tissue surrounding the cervix called the perimetrium.
You indicated that intermediate risk factors would only receive radiation. What are those risk factors?
The risk factors considered intermediate risk would be to find cancer cells into the lymphovascular space, into the blood vessels and the lymphatics surrounding the cervix, to find out at the time of the tissue cut that cancer has spread to the outer third of the cervical stroma, or to end up with a cancer which is bigger than 4 centimeters when measured.
I see. I know you're not a surgeon, but what are the side effects of surgery that you've seen in some patients?
That's a very interesting question. So what's happening is we understand is that the uterus is going to be removed with the top part of the vagina. So all this could interfere with the function of the pelvic organs. So some women after a surgery like this are found to have some kind of urinary incontinency if the nerves going to the bladder have been stretched. Also, because part of the vagina has been cut, women end up with a shorter vagina in which there is some scar tissue forming after the surgery. So difficulty with sexual intercourse is one of the side effects that could happen after surgery. And these are mostly the side effects. Also, on a longer term, there might be scar tissue forming into the pelvis, and this scar tissue could lead to obstruction, for example, of the small bowel. And this is true for any kind of surgery that would be done at the pelvic level, and these are extremely rare, those side effects, as opposed to the first one mentioned, which happen much more frequently, like the urinary incontinency and sexual dysfunction.
What if after the surgery you find out that the surgical margins are still positive for cancer? What does that mean, and what would you recommend?
So if a patient is found unfortunate to have a positive surgical margin, we need to add another treatment to the surgery in order to achieve a good local control and prevent spread of the disease. So that treatment will usually consist of radiation therapy to the pelvis, in addition to chemotherapy, which will be delivered during the course of the radiation to enhance the effect of the radiation, make our rays more powerful in order to achieve a good local control.
How much time do you give your patients to recover from surgery until they need to start radiation?
We usually wait around 6 to 8 weeks after the surgery. before starting the radiation. We know that it would definitely be suboptimal to wait more than 12 weeks for those patients. And as soon as the tissues are well healed, we need to consult the patient and get things going with the adjuvant treatment.
So just talking about radiation, to simplify it, what is radiation therapy? How do you explain that to your patients?
So radiation therapy is nothing else than the use of X-rays or photons. Same type of rays that are being used when someone goes for a chest X-ray for a diagnostic purpose. However, the X-rays that we're using for treatment are much more powerful. And as well, they are targeted to a smaller volume. And that volume that we target with those X-rays, if there's any cells in that volume which is trying to replicate, to reproduce, that cell is going to be very sensitive to the changes induced by the radiation, and this will induce a cell death. And this is why, because of that differential in the way cells react, so those replicating are going to be very sensitive to radiation, while the normal cells of our body are not always trying to replicate and therefore are going to be resistant to the radiation. By that phenomenon, we're able to kill cancer cells in the treatment field.
I see. And patients need to go for what you guys call simulation. What is that? Would you please explain that?
Absolutely. So simulation says that we just, pretend that it is like if we're going to treat the patient. So in fact, often the simulation process is done in 2 steps. In the first step, the patient is going to come for a CT scan that will be done on a table which is built exactly like the treatment table, and the patient will be positioned in the very same position that she will have at the time of the treatment. We acquire images, and then on that CT scan we're going to contour what is going to be the target. So for example, in the case of a patient who would come after surgery, we're going to target the vaginal vault, the site of positive margin, the area of lymphatic drainage in the pelvis. And we're going also to contour all the normal organs that the radiation should spare at the time of the treatment. Once those contouring are done, the computer is going to generate a treatment plan and will bring the patient back for a final, what we call marking, which is when we're going to draw the boundaries of the treatment field on the pelvis. And this is the step 2 of the simulation. Once this is done, the patient is ready to start treatment.
And how long does this take?
About a week, but there are ways that we could make this process faster. For example, if we have a patient seen in consultation who has an intact cervix which is bleeding seriously, and the patient is unstable because of that bleeding problem, then of course we're going to speed up the planning process and make the simulation happen on the same day than treatment initiation if necessary, so that we could make this treatment safe. When we have more time in a post-op setting where we could take 1 week for the simulation process, I would say this is our comfort zone. Because you have to understand that many team members have to be involved in the simulation process. It requires a lot of coordination, and ideally a week is taken to make sure that all the QA are done properly.
Okay, so let's say that the patient now is going to begin the actual treatment. How does that work? Do they need to come here? Do they go in the hospital? How long does it take?
So radiation treatment is usually delivered on an outpatient basis. And the patient is going to come to the radiation therapy department. It could be in a hospital, in a small community center, that radiation therapy department. And the time the patient will really spend in the treatment room is anywhere between 15 and half an hour, 15 minutes and half an hour. When the patient comes into the room, the first part is to do a proper setup and do some check films to confirm the positioning is adequate. The time the beam is on, so the real treatment time, is somewhere around 2 minutes. So it's a very short treatment time. And it's totally painless. When the patient is on the table, it's like going for an X-ray. You don't feel the photons coming through your body. Same thing during the radiation treatment. So it's a short visit to the hospital on a daily basis. However, we have to do that repetitively every day from Monday to Friday for anywhere between 5 and 6 weeks. So in terms of the number of fractions, this is time consuming.
Can they come alone, or do they need to come with someone else? Can they drive home?
That's a good question. So usually on the days that the patient receives radiation alone, they could be comfortable driving back home and they don't have any acute reaction that would prevent them from driving back home, and we don't need to give the patient any medication at the time of the radiation itself. So they are absolutely competent to drive back home. However, as we mentioned, some patients are going to have concomitant chemotherapy with the radiation. On the days they're going to receive the chemotherapy, on these days they have medication to decrease the side effects of the chemotherapy, and on those days they should come with someone to the hospital.
Can a patient work if they're working, or?
I do have some patients who take the decision to continue to work during the course of their radiation treatment, and this is a personal choice, and I guess the side effects could be manageable if someone really has to keep working during the course of the treatment.
So let's talk about the side effects. What are some common side effects that you see?
Yeah, so in fact with the radiation, and it's true for any kind of treatment we give in medicine, there are those side effects, the big family which we call the acute side effects. These are going to develop after the second, third week of radiation, and they could last up to a month after the end of the radiation. There are temporary side effects, the patients will heal from them. Among these, what do we find with radiation? First is increase in bowel movement frequency. They could have diarrhea. They could have increased urinary frequency during the course of the treatment. And then, because we usually give chemotherapy with the course of our radiation, the patients could have decreased blood count with some anemia, low white blood cells, low platelets, some nausea induced by the treatment, and all this could induce fatigue and a decreased appetite. These are mainly the acute side effects from the radiation. And patients will heal from this. But then on a longer term, what could happen is that any tissues which received a high dose of radiation could also develop some scarring into the tissue, some what we call fibrosis, and this could lead to another family of side effects, like, for example, rectal bleeding from a more fragile rectal mucosa. The lining of the bladder could be damaged, and this could lead some urine in the bladder, blood in the urine, on the longer term. Bowel obstruction, extremely rare. Difficulty with sexual intercourse that we discussed before. It could happen after surgery. It could also happen after radiation because scar tissue is going to form on the top of the vagina, and there are ways that we teach the patient to prevent that from happening. And finally, we have to mention that the ovaries are extremely radiosensitive, and when exposed to radiation, the ovarian function will shut down. So premature menopause for a young woman receiving radiation is one of the side effects also.
So the ovarian function most likely will not regain itself?
That's what we see in most of the situation. So in order to prevent this in younger women, what some surgeons could attempt sometimes is to move the ovaries out of what we call out of the field, or higher up into the abdomen, so that the ovaries wouldn't receive radiation. This being said, it doesn't mean that those young women would be able to have a child, would be fertile to have a child after, because the uterine function, by the fact that we gave high dose of radiation, is not going to be able to allow the patient to be, childbearing mother. But this is done to try to maintain hormones on board in young women and prevent early menopause.
I see. So could a woman experience vaginal dryness during the treatment?
During the treatment, so yes, they could, but it will mostly happen after the end of the radiation, the kind of, real dryness from the fact that the glands into the vagina will gradually stop producing the mucus, and this happens on a subacute longer term. However, what we have to mention here is we spoke until now about the kind of radiation which is called the external beam radiation, where we use photons coming through the body. A woman who has an intact cervix is going to receive another kind of radiation called the brachytherapy, where we're going to insert radioactive sources into the vagina to give a very high dose of radiation in the cancer cells, and this will induce significant tenderness and discomfort for any gynecological exam or any type of sexual intercourse for the time of the treatment and the following month or two.
Mm-hmm. And how do you handle that pain and discomfort?
So there is different ways we could handle this. First, with standard painkiller could be used, and then we teach the patient how to use vaginal douche also to keep the vaginal mucosa as free as possible of any dead tissue. This is also going to help to manage for the discomfort. And then on a longer basis, once the acute side effects have resolved, we start to use what we call a vaginal dilator to keep the tissues open into the vagina.
I see. How do you handle the nausea and vomiting that can happen with a combination chemotherapy and radiation?
So usually the patients, we will teach the patient how to use what we call free chemotherapy medication that they have on board before receiving their chemotherapy treatment. At the time of the chemotherapy in the infusion room, they will most probably receive also anti-nausea medication and leave the hospital on the day of the chemotherapy treatment with pills, with a prescription for pills that they could take at home also to prevent nausea. The radiation itself, on the days the patient receives radiation alone, it will rarely induce nausea, but on the days it is combined with the chemotherapy, the patients are strongly encouraged to use the anti-nausea pills. It is very important to prevent dehydration, to prevent weight loss, and therefore it is key to control the nausea so that the patient maintain an adequate food intake.
What about fatigue and anemia? Why are they so common in cervical cancer?
So as I mentioned earlier, one of the most frequent symptoms of women who have a cervical cancer is going to be vaginal bleeding, vaginal spotting. So to start with, often those patients will present a diagnosis with some degree of anemia that we try to correct before initiating treatment, because we know that ideally the hemoglobin is above a certain level for the treatment to work very well. But even if we correct that hemoglobin at the starting point, the woman could still have bleeding during the treatment, and then we add to this chemotherapy, which could target the blood cells, and radiation to a part of the body with the pelvic bones, which is an important area where we have our blood cells factory, and therefore this could also affect the level of red blood cells into the blood. So yes, unfortunately, women with cervical cancer are more prone to have anemia than patients with other kind of cancer because of the bleeding and the area being treated.
I see. What if the pathology of the cervical cancer is small cell versus squamous cell? Does that change your treatment or radiation?
It does change the treatment to a certain extent. So what we know of small cell cancer is that this kind of cancer has a tendency to spread to other areas of the body, and therefore we're going to change gear and move the bulk of the treatment towards tackling this risk of having cancer spread to other areas of the body, and we do this with chemotherapy. So the chemotherapy part for a patient who is diagnosed with small cell lung cancer is going to be more robust than the one which is delivered to women who have squamous cell carcinoma. And with that, even with that chemotherapy, which is more robust, unfortunately, sometimes those women do develop some kind of metastatic disease.
In what situation would you only recommend chemotherapy and radiation and not surgery?
Oh, that's a very good question. So there are those patients who, at diagnosis, are found to have risk of lymph node metastasis. And we do a CT scan, and we do find that indeed the lymph nodes are enlarged into the pelvis or even around the aorta, those women are better served with a curative treatment with chemo and radiation therapy. When we could, we like to avoid a treatment which will include what we call the three-modality treatment. I mean by that surgery, chemo, and radiation. And the reason is that when we have to put the three modalities on board, the risk of having side effects from the treatment is higher and much more significant.
Is there ever a situation in which the woman initially is not operable because the lesion is too large, but they get chemotherapy and radiation and it shrinks where it can be surgically resected?
That's a good question. First, I have to say that if to start with, the patient is definitely not deemed a candidate for surgery, as you described, we will approach this situation with chemo and radiation therapy, but hopefully with a curative implant. And surgery would not be on board as part of the initial plan for the management of that patient. However, if at the end of the treatment we see, for example, that the disease has cleared out into the pelvic lymph nodes, and the only site of residual disease is in the center of the pelvis, in the cervix, where the tumor was very significant at the beginning and we were not able to sterilize, then yes, this patient, after a secondary assessment, could become a candidate for surgery in order to achieve a cure.
I see. How do you follow your patients after surgery or radiation?
So we need to follow those patients very closely. Just one of the reasons is, as I've just mentioned, if a patient was to have a recurrency centrally in the cervix, we could offer that patient salvage treatment. So close follow-up is key in order to make sure that those patients are cancer-free, and if they are not cancer-free, to help them by drawing the best treatment plan to tackle the situation. The second reason for which we need to follow up those patients very closely is that they could develop any side effects from their cancer treatment, and we are the specialists who have the best capacity to handle those side effects. So patients are going to come back every 3 months for the physical examination, where that will include a good thorough gynecological examination with examination of the cervix, if needed, sampling of the tissues around the cervix, examination of the lymph node, and a good general physical examination. The question is, do we need to add to this other tests, like for example CT scan and all this? Some groups advocate that there is a role for a test called a PET scan about 12 to 14 weeks after the end of the chemoradiation therapy to make sure that any sites which were identified at initial diagnosis were taken care of by the treatment delivered and that the patient is cancer-free. So that's one approach that could be done. However, one would never advocate that we need to use that PET scan on a regular basis during the follow-up of the patient.
What diet do you recommend during the chemotherapy or radiation, or combined?
As I mentioned, one of the side effects from the chemo and the radiation to the pelvis is that eventually after the second week of treatment, third week, the patients are going to have increase in bowel movement frequency, looser stools, diarrhea. We know that one way to control that side effect is to adopt a low-fiber diet. It is a bit counterintuitive because everybody is proning that a high-fiber diet is very healthy and cancer patients like to have a healthy diet, and so they will throw in a lot of fibers in their diet. However, when the diarrhea starts, the way to control that problem is by decreasing the amount of fiber in the diet. To have a diet which will allow the patient to stay well hydrated.
So what would be an example of a low-fiber diet for our patients?
A low-fiber diet would be a diet in which we would avoid any raw vegetables, in which we would avoid any skin around the fruits if we're going to eat fruits, and ideally we will cook the fruits before eating them. We would go for white bread instead of the very healthy brown bread, and business things.
What do you tell your patients regarding the odds of cure of either a lymph node negative cancer or a lymph node positive cancer?
Well, I would say luckily, I like to be on the optimistic side, but cervical cancer is a cancer that we could cure when diagnosed early. thus the importance of going for those screening program and making sure that we go for regular medical attention. So if a patient is found to have an early stage, let's say stage 1B cervical cancer, and there is no evidence of any involvement into their lymph nodes, if they go for surgery, for example, those early 1B, they have a chance of being cured from their cancer, which is around 85% at 5 years. If that patient has a stage 1B cancer, but more locally advanced, bigger than 4 centimeters, and then on CT scan found to have highly suspicious pelvic lymph nodes. So now we're looking to a patient with positive pelvic lymph nodes. Unfortunately, the chances of cure are going to drop to around 65–70%. So for the same 1B, the same clinical stage, the prognosis is going to be different depending on the status of the lymph nodes.
I think what patients want from us the most is hope. How do you give your patients hope?
Well, even when the statistics could look a bit dark, I always remind our patients that human beings are not statistics. Mm-hmm. And even with darker numbers, like we could say, oh, only 65% chances of cure, but you're 100% of that winner, 60% if you are going to be the one. And I believe that a positive attitude is part of the chances of being cured, because it's going to carry the patient through the whole treatment without having to interrupt the treatment too frequently and all that. So I don't like to nurture false expectations, but when a patient has a local disease, even if it's locally advanced, we do have chances to cure that cancer, and that's what I want the patient to have in mind.
Thank you so much.
Thank you.
Thank you for watching. We hope this has been educational for you.